I'd just like to introduce Brian Robson, who is Medical Director of Healthcare Improvement Scotland, and wanted me to remind everyone he's also a GP in Newton Mearn. So I'd like to hand over to Brian to lead the next session.
Thank you very much, Gordon. Good morning, everyone. That was rubbish. Good morning, everyone.
Good morning, Brian.
Excellent. Good morning, Brian. Excellent. Morning, John at the back there. Morning, Roddy Island. Where's Roddy Island? Here's Roddy Island. Roddy, this is my day job. I work with you on a Friday in Newton Mearns, but this is my day job. So, welcome. No more PowerPoint. Is that okay? You want more PowerPoint? No, less PowerPoint. Okay. So, what we've got is a bet. So, where are all the women? Way! Okay. So, we had a whole panel full of men. Okay, so I got a glass of wine from someone at that table over there for mentioning the women, right? Now, where's Jenny Wilson? Jenny, up the back. Jenny, so Jenny gave me a bet. She said, Brian, you've got to mention the practice nurses. And if you mention practice nurses, I'll buy you a glass of wine. So, Jenny, that was the easiest bet I've ever got. And then you did something else. Then you said, and my friend Amanda, who works in Mearns Medical Centre, will buy you a glass of wine if you mention Amanda. So there you go, that's 2 glasses of wine. Yeah? I'm a very cheap date, as you know, Alan, because you've never bought me anything. Welcome everyone. This is an absolutely super session. Can I just ask, first of all, can I get the cluster quality leads to stand up? Just stand up. Okay? Keep standing. Look around. Look around at the other cluster quality leads in the room. These are people just like you, okay? They really are. They're people that put their hand up and they said, you know what? This sounds like something that is really going to make a difference. Keep standing, don't sit down. Okay, so you're all looking a bit nervous now. I'm not going to get you to do too much more, but keep standing. Now, can everyone else in the room that is here to support cluster quality leads to do a great job stand up? Okay, now look around. Okay, now give yourselves a round of applause. And you can sit back down. So all these people in the room here are here to make a difference. And cluster quality leads, as David and other speakers were saying, you're right at the very front of this, and it feels pretty scary. Doesn't it feel pretty scary? No pressure, right? So, we're going to use the next hour to try and get as much information from you as cluster quality leads as we can about how we can help. These organisations, like my own Healthcare Improvement Scotland, that you've never heard of, we all want to help you do a great job. So, on your table, you'll see one of these. Okay, do you want to just take a look at that, folks, on your table? We want you to write on this some answers to some questions we're going to be asking you over the next 50 minutes, okay? So I'll take you through the questions just in a minute, but that's the first thing. Okay, the second thing, now I don't know how good an idea this is, but on your tables, they're paper napkins, sorry, paper tablecloths, okay? Now, I've got to say to you, not every tablecloth is a paper tablecloth, okay? So please take a moment and identify the paper bit of the tablecloth, okay? Because we really don't want a big bill from the hotel.
That's the first test of quality.
That is the first test of quality. Let's see how we can make it easy to do something wrong. So, what we want to do is we want you to scribble on the paper tablecloths anything that comes to mind. We're going to be photographing them and taking them in, okay? But we've got some questions for you. So let me just run through the questions and I'll tell you how we're going to try and keep you to time on this. So this session is about trying to understand how we can help you. Seriously. The people that stood up first there, you're the people that everybody else here is here to support. We want you to tell us what the challenges are, and we want you to do it quickly. We're not going to spend a whole day doing this, okay? We want you to do it quickly. And Campbell and I have got an idea about how we might do that. And then we're going to have a 10 or 15 minute Q&A session at the end with some of the speakers from earlier on. So all the tough questions, we want you to save them up for the end of this session. So let me just run through the questions before you go to them. So the first question will be about what's happening in your GP cluster area. Have you identified areas that you'd like to improve? Okay. Second question, what challenges are you facing? And what's your biggest challenge? Third question, what does quality improvement support look like? How can we help you? What would that support look like? And also this business of a network. What would a network look like? How could we help you make connections? If you want to all come together in big rooms like this, we'll do that. If you want to come together locally, if you want a virtual network, we need your advice on how you think best we can help you network. Because those people that stood up first today, they are the people that we need to be supporting in the network. Question 4, how might you work best with the integration joint boards? I think David's talk was absolutely super. He described his journey. I think you're in the same sort of journey. In the extrinsic function of the clusters, we're really keen to hear how you think the IGBs might work. And then the fifth point we want you to be discussing is what's been the most interesting thing that you've discovered or thought about today? They seem reasonable questions? Pretty much? Okay. What's the chances of getting 200 people and 120 plus of them being GPs? What's the chances of getting through all that in 50 minutes? Yeah, pretty low. Right, okay. So what we're going to do is we're going to have 10 minutes per question. I'm going to give you a 1-minute warning when you've got 1 minute left. And then Campbell's going to play this. Okay, and then I'm going to do this. All right, so we've got 3 things to get you to move on to the next question. Does that seem enough? No. No. Ayrshire are worried that they're going to be still in the first question after 10 minutes, after an hour, sorry. Okay, so does that seem reasonable? You got the idea? We want you to be writing things down on these sheets of paper. That's really important. If you don't write anything down, we might not have anything to work with. So let's make a start, okay? What's happening in your GP cluster? Have you identified your quality improvement area? That means noise at your table. Okay. That's the end of the first question, folks. You can turn your paper over now. You're on to the second question. Okay, so the second question is, what challenges are you facing? And what's the biggest challenge? What challenges are you facing and what's the biggest challenge? Good-o. The volume went up when we talked about that. Okay. Okay, are we having fun? Excellent. Okay, if everyone can just stand up again. Stand up, everyone. Yeah, I know him. He's a pain in the neck, that guy. He really is. Right, and come on, everyone's, even the folk from Fife and, yeah, you guys, Glaswegians. And give yourself a wee shuggle. Okay, great. Not a seizure, a shuggle, Alan. Okay, everyone, you can sit back down again. Okay, I've figured out a way of getting free wine. So if I promote the various people who are trying to get you interested in their products, they're going to give me a glass of wine. So my first glass of wine comes from the Dementia Post-Diagnostic Support in Primary Care. Where's Michelle? You standing up? Where are you, Michelle? Are you here? Oh, there's Michelle at the back. So if you're interested in doing any work in post-diagnostic support in dementia and primary care, Michelle is the person up the back. Great, you'll be out there on the stand. That's another glass of wine. Okay, great. So the third question. So what does quality improvement support look like? How would it help you what can we do to help you improve? And also this network, does it work for you? Do you want to come together? How do you want to come together? Locally, regionally, nationally, virtually? Big halls like this. Okay, get talking. Okie dokie, folks. Excellent. So we're now going to move on to the next question, but who else has bought me a glass of wine? Scottish School of Primary Care. Thank you very much, Stuart Mercer. Do you want to stand up, Stuart? Give us a wave. So thank you very much, Stuart. Was that a bottle, you said? A small glass. Okay, a small glass. Okay, from the Glaswegian professor. Great. Okay, folks. So we've got some ideas from you about the support we might give. So listen, how about this business of the extrinsic? How can we contribute to the bigger system? I think both Richard and David give you a great insight into the opportunity that clusters bring to really influence the wider system. And the closer we can get with the clusters and the IGBs in particular, the more we can influence the wider system. So the next question for you, your tables, is how might GP clusters work best with IGBs? Go. Okie dokie. Lots of great ideas there, I'm absolutely sure. Now, where's Pauline Fife from Scottish Government? Pauline Fife? Pauline, there's Pauline. Hi, Pauline. We haven't met before, but apparently, according to Jess on your stand, you're going. Oh, we have met. It's my contact lenses. We have. Pauline, so your colleague Jess on the stand, which is about dermatology patient pathways. Yeah, well, Jess says that you'll buy me a glass of wine if I call out dermatology patient. 2 glasses of wine. There you go. Thank you very much. Excellent. Good. Now, okay, final question for today. There we go. What's interested you most about this morning's discussion? What's interested you most? One word, one sentence, anything you want to put down on there. Okay. Good job, everyone. Okay, so what we're going to do is we're going to clap if you can hear me. Clap if you can hear me. Excellent. It's a guaranteed way of getting a round of applause. Okay, so a big shout out to the folks at the back. If you all want to stand up, the 4-hour drivers, the 5-hour drivers, the 6-hour drivers that have come from Perth and Fife, thank you very much for persevering. Good to have you here. Okay, I've got the offer of a bottle of wine from Joseph Dehane. Joseph, could you stand up? So Joseph's a visiting fellow from Montreal, and who is it that's going to give me the bottle of wine? Yeah. You're going to give it to me, but on behalf of? Tourism Montreal. Okay, so I'm easily persuaded. So well done, Joseph. Tourism Montreal. It's a bottle of wine. And Graham, I'm going to embarrass you here because I've got another bottle of wine for doing this. So Graham, you're going to stand up now. So this is Graham Gall, who's a GP in Aberdeen, but just appointed as the National Clinical Lead for the Patient Safety Programme in Primary Care. Round of applause for Graham. So that was embarrassing, and Jill Gillis is going to give me a bottle of wine for that. So I am, yeah, okay, I'm ready. So listen, that's the end of the question. So if the panel would like to come back up on stage, that's you, Alan. Yep. Okay, so we're going to just take some roving mics and some questions to finish off this session, and then we're going to hear from Gregor for a short ending, and then Gordon is going to take us through what we're going to do over lunch and this afternoon. Do you remember the deal? The deal was if we do this just now, you can get away earlier this afternoon. Does that still sound like a good deal? Yes. Great. Good. So, who has a burning question for the panel? You just have to stick up your hand. And yes, at the back, John Nugent, just tell us who you are, John.
John, and this is just a pretend question to get it going, but what are your liver function test results?
Now, pretty good. Later, not so good. Thanks, John. Yes, here's a microphone just coming to you. Just tell us who you are.
John Hardman, I'm a cluster quality lead in Midlothian. We had one of our first proper cluster meetings yesterday, and there was an anxiety amongst the cluster about the direction of travel of clusters when it comes to commissioning and whether they could eventually be seen as organisations that could hold budgets and be replacing commissioning groups as they are in England. Is there any thought of that happening at some point in the future?
Okay, we'll go to Alan first, and David, you might
No,
have a view?
explicitly the clusters have been designed not as commercial or legal entities. They're actually just groups of professionals working together. In fact, you have to be quite careful when GPs who actually represent businesses in law get together about what they can become. So we've had to be very careful in taking legal advice to set up clusters as they are, as professional groupings to give advice to other people. Now, we will be discussing with the IGBs, etc., where, because currently you don't exist within health and social care partnerships. You stand alone at the moment, and you're not a legal entity of any kind. And we've expressly set it up like that. In fact, a number of people have wanted to do various businessy things, but you're not doing that, because if you do, you get into a whole world of legal and other commercial pain. So the answer is we explicitly set you up not to do that. Now, we will be discussing where will you sit in a health and social care partnership, but we certainly see it as an advisory role, never holding budgets. That's certainly not, that is clearly not the intention. You're an advisor to commissioners because you're the senior clinicians in the community who will make yourselves expert in how to advise on that role, but you will be in an advisory, not in a budget holding capacity. For the, that's definitely how we've set it up for the moment. I don't know if David had any other thoughts on that.
I would just endorse what Alan has said. I think that would be my view of it. That said, today we HSCPs, IJBs are commissioning bodies. They are just commissioning bodies somewhat oddly for an unscheduled care element of acute services, which is unique, in inverted commas with an exclamation mark, and bizarre model by any stretch of the imagination. I think it's a real kind of issue with the legislation that they've ended up against all advice allocating unscheduled care, which is an incredibly difficult thing to quantify in the NHS Blue Book on any day of the week. So I would say I think HSCPs are commissioning bodies just now, both of the services that we provide and deliver. I think we are in the commissioning space of primary care and community services to some extent, but it's about a dialogue and an influence about how GPs work with us collaboratively and all of that. And we are definitively going live effectively from April this year, the commissions on unscheduled care, which feels really odd to commission unscheduled care but not scheduled care. I think the direction of travel, if we stick with this model, must be that HSCPs become the commissioners of acute services. It must be. And I think in that place, that's why one of the kind of stickability challenges is GPs becoming a significant voice, not just as advisors. I think it's more than that. It's about influence, real influence over what we do to really shift the balance of care, not just keep talking about the phrase.
Okay, so it's not a technical thing that's built in, but it is something that the HSCPs will want GPs to be actively involved in. Miles, do you have a thought on this?
No.
That's good. Gregor?
I really don't have much to add to what we've already heard, because again, I don't see GP clusters having that direct commissioning role at all. Neither do I see, and I think this is also important to state, neither do I see GP clusters becoming the arbiters of quality within a system as well in terms of policing the system. I think that's really important. One of the concerns that I've heard raised by some people is what's the future for GP clusters in terms of how we will deal with practices who are perhaps maybe not benchmarking to the same level. And I don't see that as the role of the cluster to police that system at all. We've got other ways that we can provide external assurance around about that, and it's not the GP cluster.
Yep, so not inspecting other practices, but actually, as you were mentioning earlier...
It's about a supportive relationship between practices to improve quality. That's the important essence of it.
Okay, Alan?
Just to say, I mean, one of the things about separating pay from performance and also increasingly paying you for being a GP rather than running an organisation, which is currently you have a contract that runs a business and that's how you're paid, by making it, we hope, much more focused on you being a GP and providing that, that's the bit you'll be responsible for, your decisions as a clinician, not for a service that you might or might not provide. So that makes it much cleaner going forward, we hope.
Great. Okie dokie. Thank you very much for that. Now, a question at the back. Could you just introduce yourself?
Hello, my name is Gracie Bell. Thank you for having this session today. My question is around public engagement. How do we engage our patients and communities with this significant change and get them to really believe that this change is going to be good for us and for them?
Okay, so how do we engage the public and the patients? And you've just reminded me of another glass of wine. Where's Libby Morris? Libby, stand up, Libby. Okay, this is your glass of wine. So Spire is being launched on the 7th of March next week. And it's like, and the idea behind Spire is to gain the public's confidence in how we will share data and information. Is that right? Okay, the whole team can stand up for a bottle of wine. There you go. Workshops on Spire. Thank you very much. Sorry to hog your question.
Brian, we're not answering any more questions unless we get a drink.
It's all virtual wine, let me tell you.
You can tell it's a chief officer at this time of the day needs a drink.
I have to say, I'm really getting started to worry. The CMO guidelines for alcohol are going completely out the window here.
Yeah, well,
This is a BMA meeting.
The CMO is looking good, so she's doing fine. So, how about this? How are we going to engage the public and the citizens?
Well, I think there's one thing here, because it's both about the engagement with public and other professions. People have been concerned we're talking just about GPs. Well, the reason for that is it's about the GP contract. Secondarily, GPs haven't had a forum to get together and learn how to do this. And you have short enough time. So really, for you to all have conversations, have every practice involved, that's about dedicating that time. But then it's about engaging with the rest. Now, public participation occurs through IGBs and health and social care partnerships, who are the service providers. You won't be changing your role. You'll still be a GP. There'll still be other staff involved. There'll still be health practice nurses. There'll still be district nurses. So the public's perception of the change shouldn't be any different than they have now. It should get better. So and the government will consider whether or not it has to consult the public on the whole contractual change. Given the complexity of it and how difficult it is to explain it even to me, I doubt that's something in which the public could easily engage. But it's really for the service providers, the health boards, health and social care partnerships to engage with the public. And you will do so, I presume, through your locality groups as much as anything else. So this is about one aspect of that. And certainly the government's very well aware of the need. If it changes what it does to the public, then it will have to consult on that. But they will think about that. But in terms of this process, we don't currently see it's necessary to consult the public about whether you're part of a CQL or not, because you're not actually commissioning anything differently. You're not providing any different service in that regard.
Okay, but in the bigger picture, David, beyond the CQLs themselves, how about
I think it's important to remember that we do a huge amount of engagement already. So a huge amount of my time as Chief Officer is making sure that I'm leading and shaping an organisation that is engaging with all of our staff, all of our professional staff, all of our contractors, particularly. I mean, just now, if you just list off some of the routes through which we do engagement, just park the CQL issue for a minute. Our IJBs are made up of a mix of professional and other representatives, counsellors, non-executives, service users. We're required under our governance to have strategic planning groups that are essentially made up of service users, third sector organisations and others. We have service-specific engagement, so through our LD service we have families and carers and others who are engaging. Practices have that engagement also currently. We have complaints and feedback routes to do that kind of engagement. And then we have where we have material service change, we have formal engagement and consultative processes for that. So there's a ton of engagement. That said, just now, and in the last 4 or 5 years and going forward, a lot of that engagement feels negative because it's often about doing something quite different with less.
Okay, thank you very much, Miles.
I think we should stop and have a think about patients, actually. I think this is something which is worth a think. We've got a patients group in the college who've been hugely useful to us to keep us on track and make us actually grounded in actually what we're doing. All we're doing is about patient care. Unless we're getting their voice in, I think we could find ourselves in some sticky place. I absolutely take the point in the bigger strategic thing. But even some of the areas like access, some of the ways we design services, I think the patients are really important stakeholders if we're going to be honest and truthful about what we're doing. So my experience of P3 has been they've been hugely useful, hugely helpful. They are a fantastic asset when you're dealing with others, because actually if you get patients' views supporting what you do, they can be incredibly helpful in it, and to diffuse the idea that things are in any way should be self-centered to our interest in GPs. So out there, don't ignore your patients, and if there's an opportunity to involve them in some of your cluster meetings, I would think it would be a fantastic thing to try. If you do that and if it works, please let us know or let me know, because I'd like to see how that works and see what your experiences are.
Okay. Gregor, any thoughts on this?
I guess what I want to bring this back to just now is actually a discussion which kind of encompasses what we've been trying to do with realistic medicine. I'm sure you're all familiar with the CMO's report, Realistic Medicine, and how we'll start to take the steps forward to make that a reality in Scotland. One of the things that we'll start to speak about when we launch the next CMO report next week, Realising Realistic Medicine, is about how we start to get better at shared decision-making and involving patients in the care that we provide. There's lots of good examples from around the country of how we better involve patients and how we assess the type of care that we're giving to patients and our public in terms of, do we work properly in integrated teams? Do we actually properly involve people in the decisions that relate to them? And I think that one of the great prizes that exists out there in terms of the way that clusters can work in the future is actually stronger involvement and assessment of actually how we interact with our public.
Great. So ask the public. Gracie, did you want to come back on that at all, or does that answer your question? That's fine. Good. And just the chap at the back who's got the microphone, just introduce yourself.
Is that on?
That's on.
My name is Jim Cowan. I'm a clinical lead in Edinburgh, not a cluster quality lead, but a clinical lead. Just a slightly more kind of practical, operational type question. Do you think it's been a mistake not to ring fence or specify funding for the CQL appointments? Because I'm hearing there's quite a marked variation in the number of sessions that different health and social care partnerships are willing to afford.
Okay, thanks for that, Jim.
Well, I can say, I mean, currently the funding for CQL payments, which will go up to 2 a month, well, sorry, CQLs, I'm thinking of practice quality. The thing about CQLs is that they have to engage with health and social care partnerships, and if you're not going to pay for that time from GMS, in other words, practice is paying for it, then the only other people who've got money are the health and social care partnerships. So, and we deliberately left at government level, as Richard said this morning, we thought we can't tell you how to get CQLs into post, because many of you will say, I want to be employed, some will say, I want to do sessional, some will say, I'll do 3, I won't do 4. So if we said at a national level it had to be X, we probably couldn't have filled most of the posts. I imagine many of you have had to scrabble about and say, I'm not willing to give up practice, I'll do this for a period of time until we get some certainty about what you're doing. So we've left it very flexible, and for you to work and find out. Now, if it's successful, it will build. And health and social care partners will want to invest in your time to achieve more. And the system can have as much quality work as it can afford. And so that's deliberately part of it. We also made it such that neither the managers, health and social care partners had all the power, neither did the GPs. You actually had to have grown-up discussions about how you could make this work, which is quite hard. But it's real world, and it's part of the nature of the way we'll be discussing things going forward. If we're in a genuine clinician-manager partnership in these organisations going forward, you have to have grown-up discussions where neither of you have absolute power. And this has been an exercise in exactly that.
Thank you very much. So, Jim, it sounds as though it's by design rather than an error in judgment. We'll see how that goes. So let's take a question over here. Ruth, yeah. Oh, sorry, yeah. Okay, sure. Just tell us who you are.
Jürgen Titmar, GP in just outside Dunoon, NHS Highland. Gregor said that there's not going to be any element of policing within clusters about quality from each other's practices. So could you give us an idea about how clusters and CQLs are supposed to deal with practices that are dysfunctional or burnt out or plain bonkers?
Okay. We will put hands up for plain bonkers just in a moment. Gregor?
So I'm sure we don't have any practices in Scotland that are just plain bonkers.
That was rhetorical. Yep.
So this is a challenging area, isn't it? Because I think it's one of those areas where people are rightly apprehensive about what's their role going to be in all of this. The framework was designed to be a supportive framework for continuous quality improvement. Now, from my perspective, I used to be a medical director in primary care, and we had systems, checks and balances that were in place in terms of how you manage dysfunctional practices, you know, even before this was introduced. And those still exist. And we do need external quality assurance. So if you go back to the slide that I showed about the bad apples, We're not taking forward the bad apples model, but you still need a proportionate response to those practices, GPs, clinicians across the system who perhaps are causing concern of some sort. So the external quality assurance framework, which will sit round about general practice, is going to be, I guess, separate but complementary to what we're kind of talking about here today, which is about continuous quality improvement. And there'll be further discussions about actually what we mean by a proportionate response to that. So let me come on to that. What do I think the cluster's role will be? If they are coming across concerns about a practice that is in their cluster, that the quality of care that they're providing is not up to scratch, then there will be mechanisms through recognised governance frameworks within the IGB's system as to how they flag those concerns to clinical leads. And those clinical leads will have mechanisms by which they can try to verify those concerns and then put in place any kind of remedial actions against those concerns at all. Do I see that as being the responsibility of the clusters? Absolutely not the responsibility of the clusters. However, what they might help to do is shine a light on practices where they may need greater support.
Great, thanks for that, Gregor. Alan, comment, and then David.
Yeah, a couple of things on this. I mean, again, if we manage to achieve it, you'll only be actually responsible for the decisions you make as an individual or for those staff you'll directly employ. So you won't be responsible for wider services. And that chronic disease management example will be a team-based response. It won't be your job or your responsibility to make sure everything's done. So you'll be assessed mainly on the decisions you make, the clinical decisions you make, and the immediately employed staff. Now, the contract will have to include in it, if we decide that your job is partly to look at outcomes, you have to make sure you have to engage in it if it's part of your job. So we look at contractual ways to say you must engage, for example, in the quality work in the clusters, which we don't have at present very much strength in the contract on that. And so basically it'll be very similar to any clinician working. If you're not making good clinical decisions, then the clinical governance system will take that into account. Now, in terms of performance within the system, that's just wider. There'll be a much more transparent look at the data around patient outcomes. And in one way, there's no place to hide from quality. The whole system will have data based on practice collected data, which says how well the system's working. And if your local system's not working well, your peer-led arrangements will say you need to start taking steps to make that perform better. But it won't necessarily be an individual GP responsibility, it will be a system-wide responsibility. So a broadening of the responsibility for the quality of care in total, if that helps. So you'll specifically, as a clinician, be responsible for your decisions, but organisationally, the organisation and the community will be responsible for that quality of care, and it will be largely transparent to the whole world how well that's being delivered.
Thanks, Alan. Comment from David, then we'll take the final comment from Miles, and then we'll move on.
Just to, I mean, in terms of clusters changing the current rules of the game, then they haven't. The board still holds the contract. The IJB or HSCP is still the guardian of the contract. And if a practice is failing or struggling or in some way, then the old rules still apply in terms of how we would pick that up. I guess the thing that's different, two things. One is the emergence of PQLs and CQLs just give us another point of alert to flag things, not to police, but just to flag things possibly. But that's still to see how that works. Undoubtedly, though, I think every one of the CQLs will get into conversations with peer GPs with PQLs that are challenging because they do things differently. It may do things differently, not as good as you. They may do things differently, better than you. So it will lead to challenging conversations, but that's different from a practice who happens to be failing or having some real difficulties.
Miles.
This is not the CQC, and I'm very glad it's not. But I think your question is valid. I think actually what happens and how do we ensure that our patients are getting a fair crack of the whip. And I don't think there's any easy answer to that, but I will support the others in saying actually shining the light as to what's going on, developing those interactions. I think one of the big reasons why practices burn out and fail is due to lack of support and lack of visibility and just being stuck in our bunkers and doing the wrong thing with ever more confidence. So actually, if we can start to shine some lights into these bunkers, I think we're in a far better off position. But I absolutely agree, this is not taking over the clinical governance responsibilities of other people in the health boards.
Great, thank you very much. Now, if you just want to write the names of the bonkers practices in your area on your tablecloth, that would be great. I'd like to just thank the panel for us. Thank you. Thanks. And I'll just hand over to Gregor. Yep.
So I'm conscious that I stand between you and your lunch just now, so I'm not going to take long here. At the end of the day, I was going to just do a little bit of summing up as to where some of the discussions that we'd had over the course of the day sat in terms of the wider primary care transformation agenda. I think it's a really exciting time for primary care in Scotland just now. Certainly in the conversations that I have, both at a Scottish level but also an international level, I am conscious of the fact that people are looking to us to try and lead general practice and primary care into a different possible future. And I'm really quite excited about that. I've been really struck by some of the phrases that have been used over the course of this morning, particularly during the presentations. I'm going to pick out one here. Clusters are not here to fix everything. I don't think that should be restated more. It's incredibly important to understand clusters are not the panacea that is going to fix general practice and primary care. But they're a component that will help us move towards a different future in terms of the way that we work together. I think clusters have got to be seen within this wider transformation agenda because we know how difficult it is in terms of the workload that general practice in particular, but actually all clinical disciplines are experiencing just now. And I guess my one plea to all who are involved in this GP cluster work just now is that this is not 2004. This is not a big bang approach to a different future. This is an evolutionary approach that will take time and must be given time to properly come together. I don't think that we can realise the full potential of GP clusters, particularly in terms of the way that we will strive to improve the quality of care for our patients, until we have a system that sits round about it that supports this new way of working. We know that there are incredibly difficult challenges for some practices to face just now in terms of the way that they deliver care on a day-to-day basis. And so as we start to see the model of care emerging, there is much more focus on a multidisciplinary team approach. Alan has described the role of the GPs within that. Then I think that GP clusters over that time will start to realise their full potential. I was also really struck by some of the comments that I think it was David that made about some of the key aspects of the approach that were necessary for clusters. And he used terms such as staying curious, to try things, to build relationships, to be comfortable with ambiguity. For me, these are things that just define general practice for me. I came into general practice because of the longitudinal care or the opportunity to provide longitudinal care that it offered, because of the opportunity to build relationships with people and their families, and because as a clinician I was comfortable with that ambiguity and comfortable with managing clinical risk and eternally curious in terms of finding out more about people and what made them tick. And I think if we stay true to those core values of general practice, then I think GP clusters have the opportunity to kind of really work in terms of improving the quality of care that we provide for our patients in the future. So I'm going to stop there. I'm going to thank you for your participation this morning. I'm going to thank you for your questions. I had my contact details up earlier on. We'll circulate those again. Please give me feedback on the framework as it sits just now. This is a framework which I don't see as a finished article. I think the best way to describe it is a bit like software releases. We're in version 1.0 just now, and over time we'll gradually refine that and we'll make it better, and we'll take the learning from meetings such as this and recycle that into different iterations and future software releases. So thank you very much.
Just before we break for lunch, just like to say thanks very much for Brian running the last session, and for the panel for their contribution, and for Gregor's contribution there. Just quickly before we go to lunch, we have got 7 workshops this afternoon, we hope. We're missing Simon Herding and Bruce Guthrie. Oh, they are here, fantastic. So if you were going to go to that workshop, I was going to have to explain what to do, but in fact they're here, so that's fantastic. So we have 7 workshops, which will be run 3 times consecutively this afternoon with coffee in between the workshops. You all should know which workshops you're going to. If you don't, please ask at the team at the registration. And one last thing, just to say, if possible, to take the evaluation forms with you and complete them for this afternoon. That would be great. They're on the tables just now. So thank you much. If we could start again, on the timetable it says 20 to 2. If we could try and come back to, or start the workshops at 20 to 2, that would be great. Thanks so much.